It is 3 in the morning in StAMPSville. A 78-year-old woman is brought to your emergency department by her husband. She has been increasingly breathless over the last 3 days, and tonight she is confused. She does not know where she is.
This is exactly the kind of presentation that tests whether you can work in a rural hospital with limited resources. You have no CT, you have no ICU, your aeromedical retrieval is 90 minutes away, and this patient is deteriorating in front of you.
Good morning. It is Thursday, the 14th of August. This is StAMPS Daily, Episode 1, 92 days until your CGT StAMPS examination. We are in Phase 1, Foundation. Today we are building the substrate for one of the highest yield presentations you will face, the older patient with breathlessness and new confusion.
Before we dive in, today's roadmap, we start with a prioritized approach to breathlessness in the older rural patient. That is Deep Dive A. Then we move to delirium, assessment, collateral history, capacity, and the medication review that often changes the diagnosis. That is Deep Dive B. Then we bring it together with a rural integration segment where new information changes the picture. We finish with the examiner lens and active recall.
Let us start with the scenario. This is a real StAMPSville-style presentation. A 78-year-old woman, known TOPD, on tiotropium and salbutamol, lives in town with her husband. She has been getting shorter of breath over 3 days. 2 days ago she started coughing more. Her sputum changed color, and tonight she woke up confused. Her husband called the ambulance.
Tell me about her baseline. What could she do a week ago? This matters for your assessment.
A week ago she was walking around the house, cooking, and doing her garden with some breathlessness. She could walk about 50 meters on flat ground before needing to stop. Her husband says this is her normal, but since yesterday she has not been able to walk to the bathroom without severe breathlessness, and the confusion started tonight. That is a significant functional decline.
Let me stop you right there. Before you give me a differential, give me the first 45 seconds of your answer. How would you open this in the exam?
I would first assess immediate stability using an ABCDE approach. I would identify that this patient has both respiratory compromise and altered mental state, which together suggest a serious and potentially rapidly deteriorating condition. I would then define the likely and dangerous causes, begin local treatment, and in parallel decide whether this patient can remain in StAMPSville or needs retrieval.
Good. That is signposted. You told me the structure before expanding. That already separates you from the candidate who jumps straight into disease lists. Now, what are you worried about first?
The immediate threats. This patient has respiratory failure, potentially with hypercapnia causing the confusion. She could be septic. She could be in acute heart failure. She could have a pulmonary embolism. The combination of breathlessness and confusion in an older patient with CAPD narrows the initial response, even before the full differential is built.
Give me the dangerous causes and the common causes separately. I do not want them mixed.
Dangerous causes. Pneumonia with sepsis, acute heart failure including from an acute coronary syndrome, pulmonary embolism, COPD exacerbation progressing to type 2 respiratory failure, and a medication-related cause, particularly if she has been taking more sedating medications. The common causes overlap: COPD exacerbation, community-acquired pneumonia, congestive cardiac failure, and a urinary tract infection causing delirium with secondary breathlessness.
Why is the medication cause on your dangerous list? That sounds like it belongs with the common causes.
Because in a patient with COPD who is confused, the most dangerous medication issue is excess opioid or benzodiazepine use, suppressing her respiratory drive. Many COPD patients are prescribed opiates for dyspnea or benzodiazepines for anxiety. If she or her husband has been giving extra doses to manage her breathlessness at home, that could be the cause of both the respiratory depression and the confusion.
That is specific. Now, what focused history and examination are you doing? Remember, you have no CT, limited bloods, and a bedside ultrasound.
History is mainly from the husband as collateral. Onset, progression, sputum changes, fever, chest pain, leg swelling, urinary symptoms, medication changes, and baseline functional status. I need to know what she could do a week ago. On examination, I am looking at the whole picture: respiratory rate, oxygen saturation, accessory muscle use, and the shape of the chest. Auscultation for wheeze, crackles, or reduced air entry. Cardiovascular for jugular venous pressure, murmurs, and peripheral edema. And a careful cognitive assessment.
Stop at the cognitive assessment. How are you assessing cognition in a confused patient? Are you doing a mini-mental?
Not as the first step. I am doing a rapid delirium screen. The key question is whether this is an acute change from baseline. The husband confirms it is. I am using the confusion assessment method, which looks for acute onset and fluctuating course, inattention, and either disorganized thinking or altered level of consciousness. A formal cognitive score can come later once she is stabilized. Right now I need to know if this is delirium or a chronic dementia. The answer changes the urgency.
What investigations can you actually do locally tonight?
Point of care. I can get a blood gas immediately. That tells me pH, PCO2, PO2, bicarbonate, base excess, and lactate. I can check hemoglobin and hematocrit at the bedside. I can check INR if she is on warfarin, and troponin if I suspect a cardiac cause. A chest x-ray is available, and I have bedside ultrasound. For formal bloods, the full blood count, UNE, liver function tests, and CRP will be couriered to the regional lab, but those results take time. I am making decisions tonight on point-of-care data.
Blood gas. Walk me through what you are looking for and what it tells you.
3 things. First, is she hypoxemic? A PO2 below 60 on room air confirms significant respiratory failure. Second, is she retaining CO2? A PCO2 above 45 millimeters of mercury with a low pH below 7.35 means type 2 respiratory failure. That is the scenario where uncontrolled oxygen can be dangerous. Third, the lactate. A lactate above 2 millimoles per liter raises concern for sepsis or tissue hypoperfusion. Above 4, that is severe. The blood gas is the single most important investigation I am doing in the first 10 minutes.
You mentioned oxygen can be dangerous. Explain that. What target are you aiming for in this patient?
In a known COPD patient, the target oxygen saturation is 88 to 92%. The COPD-X guidelines are explicit on this. Controlled oxygen delivery, half a liter to 2 liters per minute via nasal prongs, or a venturi masker 24 or 28%. The The reason is that some COPD patients rely on a hypoxic respiratory drive. If you give high-flow oxygen and push their saturations to 98 or 99, they may stop breathing effectively, retain CO2, and develop carbon dioxide narcosis. This patient is already confused. I do not want to push her into coma with uncontrolled oxygen.
And if she is already on oxygen when she arrives, the ambulance crew may have put her on high flow.
That is a critical point. I would check what the ambulance gave her. If she arrived on a non-rebreather mask at 15 liters, I would reduce to controlled oxygen immediately, recheck the blood gas in 20 to 30 minutes, and watch the CO2 trend. If her PCO2 is rising, I need to think about non-invasive ventilation.
Non-invasive ventilation. What is your threshold? When do you start BiPAP?
The indication is type 2 respiratory failure that has not responded to initial medical therapy. If her blood gas after 30 minutes of controlled oxygen and bronchodilators shows a pH below 7.35 with a PCO2 above 45, that is COPD exacerbation with acute hypercapnic respiratory failure. I would start bilevel positive airway pressure. Start with an inspiratory pressure of 10 and expiratory pressure of 4, and titrate up based on the blood gas response.
You have an Oxylog ventilator in StAMPSville. Do you have a BiPAP machine?
The Oxylog can deliver non-invasive ventilation with the right circuit and mask, and many rural hospitals stock a dedicated BiPAP device for exactly this scenario. I would clarify what is available, but the key point for the exam is that I am making a ventilatory decision based on blood gas, not guessing.
Pharmacologically, what are you giving right now? Give me drug, dose, route, and monitoring for each.
Salbutamol, 5 mg via nebulizer. Repeat every 20 minutes for the first hour if needed. Monitoring for tachycardia, hypokalemia, and tremor. Ipratropium, 500 micrograms via nebulizer, up to every 4 hours. Prednisolone, 30 to 40 mg orally for 5 days, or IV hydrocortisone 100 mg if she cannot take oral. The COPA-DX guidelines recommend oral prednisolone 30 to 50 mg for 5 days. Monitoring blood glucose, especially in diabetics.
Antibiotics. Are you giving them? Which one, what dose, and why?
This depends on the likely source. If the picture is a COPA-D exacerbation with purulent sputum and increased volume, the COPA-DX guidelines recommend amoxicillin or doxycycline for 5 days. Amoxicillin, 500 mg to 1 gram orally 3 times daily, or doxycycline, 200 mg loading then 100 mg daily. But she is confused and may not tolerate oral, and if she has features of sepsis or moderate to high severity pneumonia, I am going broader.
How much broader? Give me the exact regimen for moderate severity CAP, needing IV antibiotics.
For moderate severity community-acquired pneumonia, in a patient needing admission, the therapeutic guidelines recommend benzylpenicillin, 1.2 grams intravenously every 6 hours, plus doxycycline, 100 mg orally or IV daily, or a macrolide like azithromycin, 500 mg daily. If I suspect sepsis from pneumonia, I am giving benzylpenicillin within the first hour, and the ACS-QHC sepsis clinical care standard is clear. Antibiotics within 60 minutes for suspected sepsis.
1.2 grams IV 6 hourly. What if she is penicillin allergic?
Ceftriaxone, 2 grams intravenously daily. The therapeutic guidelines recommend ceftriaxone as the alternative in non-severe penicillin allergy. If she has anaphylaxis to penicillin, I would consult and consider moxifloxacin, 400 mg daily. But in a rural setting with limited options, ceftriaxone is the practical alternative for most penicillin allergic patients.
Before we move to delirium, you listed pulmonary embolism as a dangerous cause. She has COPD, she is breathless, and she is confused. PE is plausible, but you have no CT and no D-dimer tonight. How are you making that decision?
Clinically, I am looking for risk factors: recent immobilization, recent surgery, active cancer, a history of VTE, and on examination, leg swelling suggesting DVT. I can use the Wells score to stratify, but in a patient with a clear alternative explanation like COPD exacerbation with infective features, the pretest probability is lower. If I am genuinely concerned, I can do a bedside ultrasound looking for right ventricular strain, a McConnell sign. If I see right heart strain on bedside echo with a compatible clinical picture, that strengthens the case for PE.
And the practical decision in StAMPSville?
If I suspect PE strongly enough, I am retrieving her for CT pulmonary angiography at the regional hospital, but I would not empirically anticoagulate without a reasonable pretest probability, because this patient may need invasive procedures and she has limited blood products available. The threshold for retrieval is whether PE is the most likely diagnosis or a competing diagnosis I cannot exclude.
That is a fellowship level answer. You acknowledge the limitation, used what you have, and stated your threshold for action. Let us move to Deep Dive B. Deep Dive B: delirium in the older patient. You said the confusion started tonight. The husband confirms this is not her baseline. Walk me through your delirium assessment.
Delirium is an acute disturbance of attention and awareness, with a fluctuating course, representing a change from baseline. It is caused by an underlying medical condition. In this patient, the breathlessness and the confusion are almost certainly linked. The delirium is a symptom of the underlying illness, not a separate problem.
What are the most common causes of delirium in an older patient presenting to a rural hospital? Give me your framework.
I use the acronym Deliriums: drugs and toxins, electrolyte disturbances, lack of drugs meaning withdrawal, infection, reduced sensory input meaning hearing or vision, intracranial meaning stroke or bleed, urinary retention and constipation, metabolic, including hypoxia and hypoglycemia, and sleep deprivation. In this patient, the most likely causes are infection, hypoxia, and drugs.
You mentioned drugs again. What specific medications are you worried about?
I want to know every medication she takes, not just the prescription list. I want the husband to bring in all the bottles from the bathroom cabinet. In a COPD patient, the key culprits are benzodiazepines prescribed for anxiety or insomnia, opioids for pain or dysmania, anticholinergics including some inhalers, and over-the-counter sedating antihistamines. If she has been taking extra doses of any of these because she felt breathless at home, that could contribute to both the respiratory depression and the delirium.
Capacity assessment. This woman is confused. Can she consent to treatment? Walk me through that decision.
Capacity is decision-specific and time-specific. I would assess her capacity to consent to the immediate treatment, which is oxygen, IV access, blood tests, and antibiotics. The test is whether she can understand the information, retain it, weigh it, and communicate her decision. Given that she does not know where she is, she likely lacks capacity for this decision right now.
And what do you do if she lacks capacity?
I treat under the doctrine of necessity, or implied consent in an emergency. If the treatment is immediately necessary to save life or prevent serious deterioration, and she cannot consent, and there is no advance care directive refusing treatment, I proceed. I would document the capacity assessment and the rationale. I would involve the husband as her person responsible, or nearest relative, depending on the jurisdiction. But in an acute emergency, I do not wait for formal substitute consent if treatment is time critical.
Jurisdiction. Which state is StAMPSville in?
The community profile does not specify a state or territory. For the exam, I would state the general principle and note that the specific guardianship and mental health legislation varies by jurisdiction. I would practice the general framework, understand the information, retain it, weigh it, communicate. Emergency treatment under necessity, involve the person responsible. And for non-emergency treatment, follow the relevant guardianship act or equivalent.
Good. Now, you said the breathlessness and confusion are linked. What if they are not? What if the delirium has a separate cause?
That is always possible. The delirium could be from a urinary tract infection, with the breathlessness from a COPD exacerbation triggered by the infection, or she could have a stroke causing both confusion and respiratory embarrassment. That is why the workup includes a bedside ultrasound, a blood gas, and a careful neurological exam. But the principle holds. In a patient who presents with an acute systemic illness and delirium, the delirium usually resolves when you treat the underlying cause.
Let us evolve this scenario. Your blood gas comes back, pH 7.29, PCO2 75, PO2 52 on 2 liters, lactate 3.2. The chest X-ray shows right lower zone consolidation. What does this change?
It changes everything. She has type 2 respiratory failure with acidosis. The lactate suggests sepsis or significant tissue hypoperfusion, and the consolidation confirms pneumonia. This is a COPD exacerbation triggered by community-acquired pneumonia, progressing to hypercapnic respiratory failure and sepsis. My immediate actions change.
Tell me exactly what changes. What are you doing differently right now?
First, I am starting non-invasive ventilation. BiPAP, inspiratory pressure 10, expiratory pressure 4, titrated to blood gas response. Second, I am formally treating this as sepsis. The ACSQHC sepsis clinical care standard requires blood cultures before antibiotics if possible, serum lactate, IV fluids and antibiotics within 60 minutes. I already have the lactate from the gas. I would take blood cultures, give a fluid bolus and start benzyl penicillin 1.2 grams IV and azithromycin 500 milligrams within the first hour.
Blood cultures. Your formal labs are couriered 3 times a week. How are you getting cultures processed?
I would draw the cultures locally and store them appropriately. The courier collects 3 times a week. I would flag this as urgent and request expedited processing at the regional lab. The key point is that cultures are drawn before antibiotics. If the courier is not coming for 2 days, I label store and send. The result comes back later, but I do not delay antibiotics for the courier.
You said IV fluids. How much? What fluid? And what is your monitoring?
For sepsis with suspected hypoperfusion, the surviving sepsis guidelines recommend a balanced crystalloid, 30 milliliters per kilogram body weight in the first 3 hours. For a 60-kilogram woman, that is 1.8 liters. I would give 1 liter of Hartmann solution over the first 30 minutes to an hour, reassess, and give further fluid based on response. Monitoring is blood pressure, heart rate, urine output if she has a catheter, and repeat lactate. If she is not improving, I am thinking about early vasopressors, but I do not have noradrenaline infusing locally in most rural hospitals. That is where retrieval comes in.
Retrieval. You said you would call early. Walk me through the retrieval timeline. The aircraft is 90 minutes away. What happens in those 90 minutes?
I am calling retrieval coordination as soon as I have the blood gas. My handover is structured. SBAR. Situation. 78-year-old woman. COPD exacerbation with pneumonia. Type 2 respiratory failure with pH 7.29. Lactate 3.2. Background. Known COPD. 3-day deterioration. Confusion. Assessment. On BiPAP. Antibiotics given. Fluid bolus running. Request. Intensive care retrieval for ongoing ventilatory and vasopressor support.
What happens while you wait for the aircraft?
I am doing 5 things in parallel. Stabilizing the airway and ventilation. Reassessing the blood gas every 30 minutes. Titrating BiPAP settings, monitoring for clinical deterioration, preparing the transfer paperwork and medications, and communicating with the family. I need a nurse monitoring her continuously. I need the retrieval plan documented. I need the family to understand what is happening and where she is going.
Who is on your team tonight? Who are you delegating to?
I have a registered nurse on shift. I may have a remote area nurse available. I am the only doctor. I would explicitly assign roles. Nurse 1, continuous monitoring, medication administration, BiPAP adjustment as directed. Nurse 2 or remote area nurse, drawing up medications, preparing transfer equipment, communicating with the family if I am busy. I am the team leader. I do the clinical assessment, the blood gas interpretation, the retrieval call, and the overall plan. I am explicit about delegation. I do not assume people know what to do. I tell them.
The husband. He is in the waiting room. He is frightened. How are you communicating with him?
I would speak with him directly, early, and honestly. I would explain that his wife is seriously ill, that she has a chest infection that has affected her breathing and her thinking, that we are treating her with oxygen through a mask, antibiotics, and fluids, and that we have called the flying doctor to take her to the regional hospital where she can have more intensive care. I would ask about her wishes. Does she have an advanced care plan? Has she ever talked about intensive care? I would document the conversation, and I would make sure someone is checking on him. A frightened family member alone in a rural hospital waiting room at 4 in the morning is part of the care I am providing.
Cultural safety. The StAMPSville population is 35% Aboriginal and Torres Strait Islander. What changes if this woman is Aboriginal?
Everything I have said clinically still applies, but the context changes. I would consider whether an Aboriginal health worker or Aboriginal liaison officer should be involved in the family conversation. The husband may have specific cultural needs around communication, decision-making, and the hospital environment. If English is not his first language, I would arrange an interpreter. I would be aware that the history of health services for Aboriginal people means trust is not assumed. I would be explicit about what I am doing and why, and I would consider the practical issues. If the husband does not drive, or if the family lives in one of the communities 75 or 180 kilometers away, the transfer to the regional hospital creates a geographic and financial burden. I would involve social work or the Aboriginal liaison officer to help with travel and accommodation.
That is specific and integrated, not a generic consider culture sentence.
The community profile is not decoration. It is a clinical reasoning input. The 35% Aboriginal population, the remote communities, the travel distances, the limited services, these factors change the plan.
What about notification? Does this presentation trigger any public health reporting?
Not in this case. Pneumonia is not a notifiable disease in most Australian jurisdictions, but if the underlying cause were a notifiable infection like influenza, COVID, or tuberculosis, I would notify the public health unit. And if I suspected elder abuse or neglect, which I have no evidence of here, that would trigger mandatory reporting obligations. The principle is to consider notification as part of the management plan whenever infection or safeguarding is relevant.
Examiner lens. The public assessment reports repeatedly flag one weakness. Candidates default to referral before showing assessment and initial management. Let me play that back. A generic candidate might say, I would admit her and transfer her to the regional hospital. That is a 3 out of 7 answer. What makes your answer a 6?
A generic answer skips the assessment. It tells the examiner nothing about clinical reasoning. The 6 out of 7 answer shows the work. I assessed stability. I interpreted the blood gas. I made a ventilatory decision based on objective data. I started the sepsis bundle within the first hour. I called retrieval early with a structured handover. I delegated explicitly. I communicated with the family, and I stated my escalation triggers. The examiner can see the reasoning chain.
Let me push you on something. You said you would start BiPAP. What are the contraindications? When should you not use it?
Contraindications to non-invasive ventilation include cardiac arrest, respiratory arrest, inability to protect the airway, facial trauma preventing a mask seal, copious secretions, and agitated delirium where the patient cannot cooperate with the mask. This patient is confused, but if she is agitated and pulling at the mask, BiPAP will fail. I would try it, monitor closely, and if she cannot tolerate it or her consciousness drops further, I am moving to intubation and mechanical ventilation. But that is the point where I need the retrieval team. Intubating and ventilating a COPD patient in a hospital with no ICU is a holding measure until the aircraft arrives.
Another recurring theme. Follow-up. Candidates often miss this. What is your follow-up plan for this patient, assuming she survives and returns to StAMPSville after the admission?
After discharge from the regional hospital, she comes back to my care. I need a structured follow-up plan. Medication review. Is her COPD inhaler regimen optimized? Should she be on a LAMA-LEVA ICS combination? Pulmonary rehabilitation referral. Smoking cessation if she smokes. Vaccination status. Pneumococcal influenza, COVID and RSV vaccines as appropriate. Advanced care planning. This admission is a signal that her COPD is severe. I should discuss her wishes for future exacerbations. And I need a written COPD action plan, so the husband knows what to do next time she deteriorates. He needs to know when to call the ambulance, when to start prednisolone at home, and when to come in. The follow-up is not an afterthought. It is how I prevent the next 3 a.m. presentation.
Active recall. I'm going to ask you 2 questions. Take a moment to think. First, give the first 45 seconds of your structured answer to this scenario.
I would first assess immediate stability using ABCDE. I would identify that this patient has respiratory failure with hypercapnia and an acute confusional state. I would obtain a blood gas within the first 10 minutes, start controlled oxygen at COPD appropriate targets, give bronchodilators and steroids, and make a ventilatory decision based on the blood gas. In parallel, I would treat for sepsis with antibiotics within the first hour and call retrieval early with a structured handover.
Second, what can you investigate locally tonight, and what cannot you do?
Locally, I can do blood gas, hemoglobin, INR, troponin, chest x-ray, ECG, and bedside ultrasound. Formal bloods are couriered to the regional lab 3 times a week. I cannot do CT, MRI, or after-hours formal ultrasound. I cannot do BNP. Decisions tonight are made on point-of-care data.
Let us recap. 3 things you must say in the exam if you get this presentation.
1. I would assess stability first, then build a prioritized differential that separates dangerous from common causes. 2. In a COPD patient, target oxygen saturations 88 to 92% and make the BiPAP decision based on blood gas, not guesswork. 3. Treat sepsis within the first hour with the ACS-QHC bundle and call retrieval early with a structured handover. The aircraft is 90 minutes away. Stabilize in parallel, not after.
Tomorrow we tackle acute chest pain in a town with no CT. Differentials include STEMI, aortic dissection, and pulmonary embolism. Thrombolysis decisions, telehealth cardiology, and what you can do with an ECG and a troponin. See you at D-91.
Study well. See you tomorrow.